Good evening, everyone, or if you're watching a recording, could be any time of the day, depending on where you are in the world. I want to personally thank everyone for registering tonight. We had an almost record crowd, I think about 700 of you. And the only reason why I bring that up is because, well, one, I'm glad so many people turned in, but number two, it just goes to show that something as basic as our prep designs for restoring teeth, that should just be inherent to us, right? And by the amount of people that signed up for the webinar tonight and that are currently on, it just goes to show that there's definitely a demand for understanding restoring teeth, okay? And I know many of you, like myself, have had a very long day and you may have been restoring many teeth, and tonight we're going to talk about restoring more teeth. But I definitely want to make sure that this hour is worth your while. And I'd like to maybe kind of expand upon some of the things you're doing now, even if you walk away and you've only changed 2 or 3 things as far as your armamentarium or how you think about prep design, how you think about engineering for teeth, what burrs you're using, what restorative materials you're using in the posterior, then I've done my job, okay? You will get my contact information. So if there's only so many questions we can answer tonight, but if you do have a question, if there's something that I discussed that doesn't make sense to you, or you have a counterpoint, or you just want more information on, I really pride myself on always being available. So please reach out to me via email, and hopefully I can answer your questions. Okay, so away we go. So tonight we're going to do 2 things. Number one, we're going to have a didactic portion. I'm going to go through slides. And the other thing that I love to do on these webinars or live courses is switch to the microscope, because it's one thing just me showing you photos and maybe some recorded videos. More importantly, I want to show you start to finish a prep for a class 2 composite on a permanent tooth. And then we're also going to prep a few extracted human teeth that we've got mounted in stone to show you the burrs that we're going to be using tonight. I don't know about all of you, but I'm sure many of you on are owners of practices. And I will tell you, post-COVID, dentistry has not gotten any easier, right? Our overheads have gone up, our patient demands have gone up, and practicing is already hard enough. So if there's some things I can do tonight to make your direct restorative easier, I would love to do that for you. These are really my goals. And any time that I'm teaching docs on direct restorative, I want things to be predictable. I joke I want it to be like fast food. I know that sounds funny, but you just hit a button, you make the hamburger. That's it. That's what we want for a restorative. It's different in the anterior. We're talking about aesthetics. We're talking about color matching in the posterior. Don't get me wrong. Aesthetics are important, but I want your restorative results to be predictable, where you prep that tooth perfectly, you put your matrix in, you did your injection molding, you polished, patient bites, everything's great. And if you take a post-op x-ray, that it looks exactly how it was designed for. And that's not always the case, I find, especially with a metal matrix. So I want it to be prescriptive. Everything I show you tonight needs to be ABC, 1, 2, 3. I don't want you to have to think about, well, what's the next step? I want things to be logical for you. I want you to actually have handouts available. So if you want to restore teeth or prepare teeth like I'm going to show you tonight, that you're able to do that very easily just with a checkoff guide. I want your dentistry, especially your restorative in the posterior, to not take much time. I would love for you to enjoy what you do every single day, right? And sometimes I know I personally love restorative dentistry. Sometimes running the practice and dealing with the business side can be not as enjoyable, but I truly love restorative dentistry, especially in the posterior, okay? And I want things to be aesthetic for us and profitable, right? In education, I know talking about profit, it's kind of a bad word. And I think, though, it's important to discuss that we have to be profitable in what we do, right? You've got to pay your employees, you have to pay your light bill. And so if you're taking a long time, if you're redoing restorations, that definitely gets into your profit margin. Just a little bit about me, just to get out of the way, I am a pediatric dentist. Now, a lot of times I don't tell groups, I was, speaking a big group in front of GPs or prosthodontists, and I think, well, what is a pediatric dentist, giving us instruction on restoring teeth? During my training, I fell in love with restorative dentistry. I did a master's program through the Department of Oral Biomaterials at UT Houston in conjunction with my pediatric residency. And what I found is I love marrying the laboratory with what happens clinically. And for almost, actually, probably most of my career, I've taught general dentists and prosthodontists and orthodontists and pediatric dentists. So I'm going to give you an overview tonight, not just in the eyes of a pediatric dentist, but someone that's restoring teeth and restoring a lot of permanent teeth. We're really going to mostly talk about restoring permanent teeth tonight. My information is there, so Joshua at pediatricdds.com. One of my websites is there as well, and that's just a quick overview of my office. We recently, well, it's about 2.5 years ago now that I moved into a new office that has a training center built in. And if you want it on the upper right, it's just a QR code to get to my information. And this is what I study in my master's program. I learned how to use an Instron. I learned how to take human teeth and section them. But what I didn't understand in residency and when I did my master's thesis was what happens in the laboratory can be very different than what happens in the mouth. In the laboratory, you don't have teeth covered by biofilm. You don't have employees that are asking you questions as you're trying to work. You don't have a patient that you're trying to make sure they're happy and at the end they're satisfied with your treatment. So hopefully tonight it will be a great kickoff here for you to change maybe some of the ways that you restore teeth. Just a few descriptions and a few disclaimers I want to make. So I was given honorarium to speak tonight. However, I do not present on products or on processes or on armamentarium that I do not use on a daily basis. I tell everybody, I challenge you, you can come to my office. If you want to see the materials I'm using tonight, that's what I use on a daily basis. The burrs I show you tonight, I use those on a daily basis. So I'm never just a hired gun where just talking about some product just because someone pays me to do so. That would be the worst thing I could do as an educator. Some of the slides tonight, most of them are my cases, not all of them. I have clearly delineated which ones are my cases or KOL slide decks from companies. The other thing is I don't have all the solutions. So I'm going to show you how I restore teeth, how I teach other dentists to restore teeth, but there are other good materials out there. There are other ways to restore teeth that I'm not going to discuss, but I'm just going to show you what I know. And again, I don't show materials or supplies that I don't use on a daily basis. 3M, which is now Solventum, SS White, and Bioclear helped to sponsor tonight, and thank you for that. I am part of, as Sophia mentioned, I'm part of the Catapult group. So they are an amazing group of specialists and clinicians. I think we offer, hands down, the best online and in-person dental education in the world. I do, as I mentioned, I do run one of the Bioclear teaching centers, and we're all over the world. I run the one in California. There we are, that blue there. That's where I'm tonight, which I'm in Livermore, California, which is Northern California. And also, all of the methods and materials that I'm going to show you tonight are not something that just, we talk about in private practice. There are all those, and this is just a short list of institutions that are teaching what I'm going to show you tonight on a daily basis. There are 5 dental schools in North America that stopped teaching GB Black, that just teach a Clark Class II injection molding using all the materials that we're going to discuss tonight. If you're a pediatric dentist and you're interested in learning more, now I will show you links later for general dentists, but if you're a pediatric specialist, this is our 2-day course that we give at pediatricdds.com, and we go into the anterior and posterior, 4 different sites throughout the country. So if you want to join me, I'm the one who teaches all the courses. I do have other instructors that help. It'll just expand upon what we're going to discuss tonight. Although we're not going to really get into treatment planning, I do want to discuss something that I find unbelievably helpful, and I would not want to practice without it. Whether you like it or not, AI is here to stay. And I use AI for all my caries detection in the posterior for my practice. It's something I find that not only does it increase my accuracy, but it's really as much of a tool to communicate with patients. And I had this down for a couple of weeks while we were doing some server upgrades, and I just did not want to practice again without it. If you do want information, this is for Pearl. There are other AI companies for caries detection. We were the first office in the country to integrate Pearl directly into Eaglesoft, so it's something I am very passionate about. And if you find it something that you want more information on, you can scan the QR code there. One other device, again, they are not sponsored. I don't get paid for talking about this, but I have found has changed the way that I diagnose and the way that I communicate to patients. This is Cabo's DiagnoCam, and it really is a 3-in-1 camera. And not only does it take normal HD intraoral photos, it gives us fluorescence, which picks up the porphyrins and bacteria so we can see caries. But what I find is the most fascinating here is it has two transillumination tips there, and they surround the both buccal and lingual, and it just uses NIRT, which is near field infrared transmission of light. And it will not only show you if they're caries, but with the bite wings, we just see kind of depth. This actually shows me the 3D anatomy and the progression of that lesion, both facial lingual and interior in the tooth. So I know exactly where I need to go to drop in, because I don't want to make my preparations too wide. I want to minimize the amount of enamel I'm removing off teeth. And if possible, I want to see exactly the 3D shape of that tooth. And this tool I've been using now for, I think, at least 4 or 5 months. It's made a huge difference in how I treatment plan. If I was going to give a clinician a summary of the 3 things that I think are most important, especially for posterior composites, number 1 is going to be magnification. Okay, I see docs that come and train with me that don't have loops, they don't have any type of advanced magnification, and I see the difference for those docs that come in at 4.5 to 5.5. In my personal opinion, not studied based, but in my personal opinion, 4.5 really is the sweet spot at the lowest, I should say, magnification that I would want some clinician to use in my mouth when restoring teeth. We're going to discuss just briefly tonight the importance of using disclosing solution. You see the pink and purple liquid that's on there, and removing biofilm with a tool that allows us to spray water and pressure and a mild abrasive. If there's one thing that you're going to do to change the bond strength and the success rate of your posterior restorations, actually any restoration in the mouth that you're using adhesive dentistry, it's going to be just using disclosing solution and removing that biofilm here's a Bioclear blaster. There's a few different devices we can use to remove biofilm. And then a lot of what tonight we're going to talk about is using heated and injection molded composite and a matrix that's actually shaped like the tooth. If you would have told me years ago that I could never restore tooth again without heated injection molded composite, I wouldn't even know what those terms mean, but we're going to discuss that in detail tonight, okay? I'm going to show you, these are the 5 pillars of the method that we use to restore teeth. Number 1 is always biofilm removal. We need to clean the outsides of the teeth. You wouldn't think about painting your house without pressure blasting it first. That's the most important step out of everything. We're going to spend a majority of tonight talking about preparation design for the posterior and learn why having engineering-based preparations and burrs specifically for the posterior is absolutely vital into providing the best care possible. I'm going to show you some matrices in the posterior, and this is maybe something you've never seen before. It's a clear matrix. If I have a clear matrix that actually can cure through and that's shaped like the tooth, my life becomes much, much easier. We're going to show some slides here on injection molded composite, heated injection molded composite. The basics there is it changes that viscosity of the resin. It becomes much more easier to inject, actually about 81% easier to, less pressure that you have to place and easier to inject into our preparation. And then we'll maybe touch a little bit on finishing and polishing. At the beginning, I talked to you about giving you a prescriptive method of restoring teeth. And that's what I have available for you here. Step-by-step guides, and we'll make these available to you. Step-by-step guides in preparing teeth in the posterior, and then also what are the steps start to finish from disclosing all the way to polishing our posterior composites. Before we get into discussing how to really prepare teeth with modern preparations and how to restore teeth, I think it's important to talk briefly about why do composites fail, especially in the posterior. And unfortunately, we have this epidemic of failing composites. If you've been out in practice long enough, I think you don't need a study to see this. You see it in your patients every single day. Posterior composites are technique sensitive. If I don't have a matrix actually shaped like the tooth, and I have a matrix shaped like a cone, that's kind of the results that I see on the upper right there. It never made sense to me. If you look at this restored tooth, why would we put the margin, the most tenuous part of that restoration, in the same place where that patient could not keep their tooth clean in the first place? Makes absolutely no sense. And there are, I could give you a deluge of studies of showing that the success rate of having long-term restoration of the posterior is low. I mean, this study, 500,000 restorations were tracked over 11 years, and 23% of composite restorations failed before 2 years. I mean, that's an awful number. I don't want any of my teeth or my patient's teeth in that pile. I find that posterior composites are difficult for docs because we've not been given a step-by-step method. Any of us that's on the webinar tonight, you could give us all the armamentarium to place a posterior class 2 amalgam, and most of us are going to do a perfect job. And the reason being is their prescriptive method. We were all pretty much taught the same way. And there's G.V. Black with the Wiedelstadt prepping teeth like they did in the 1800s. And I hate to tell you, that's how most dentists prepare teeth today. So why do posterior composites fail? Number one is improper isolation. We get water, we get bleeding that gets into our preparations. And unfortunately, none of these materials, or most of these materials we use, are not moisture tolerant or bleeding tolerant. If we don't remove biofilm, failure to use a pre-wedge to separate the teeth. Metal matrices, now that you can still do good dentistry with a metal matrix, but I find getting curing depth and actually having that tooth look like a tooth when I'm done, it's much more difficult with a metal matrix, okay? I want to have my contact at the junction of the occlusal middle third of all my posterior teeth, and often that is much more difficult with a metal matrix. IFU, when you open your composite, remember there's a little thing that drops out, that's the instructions, and I find many clinicians just fail to follow the basic instructions that come with that restorative material. And this is the big one tonight, preparation design based on amalgam. You may hear me repeat this several times, composite is not white amalgam, and we're going to discuss why. And there you go, there's G.V. Black in the 1800s, before we had the telephone, before we had the germ theory. These were retentive box preps, and that's the last thing they want for adhesive dentistry. So how is this preparation different? That's what we're going to spend a vast majority of tonight talking about. And when we get into restoring teeth here closer to the end, you're going to see that if you give me a metal matrix that's shaped like a cone, that's going to be the result that I have in many, many of my restorations. And with metal, we have this issue with, pinpoint contacts and burnish contacts. I want a matrix actually shaped like the tooth, and these matrices are definitely not shaped like the teeth. Biofilm removal, we talked about this at the beginning. This has to be the number one step that we do. Any tooth in my practice is getting a sealant, it's getting occlusal, it's getting a class 2, it's getting an anterior composite-based restoration. We're putting disclosing solution on the tooth itself first. After that disclosing solution goes on, we use a device that has pressure and water and a mild abrasive to remove that biofilm off the teeth. You cannot see biofilm, you can't see those proteoglycans or that protein pellicle on the tooth without using disclosing solution first. The powder that I use in my units is aluminum trihydroxide. So now that's different than aluminum oxide, okay? Aluminum oxide we use in the laboratory, we use to cut teeth. This is aluminum trihydroxide. So the Bioclear blaster there is one of the devices I use in my practice. This thing is bulletproof. It cleans up easily, sterilizes easily. We use it all day, every day. This is simply enough pressure to remove that organic layer off the tooth, all the plaque, all the biofilm, all the protein pellicle, and I'll demonstrate that for you tonight. Before we discuss and I show you prep design, let's talk about the modern class 2. So this is now the opposite of what I showed you earlier. Proper isolation. It's rubber dam, rubber dam, rubber dam. Yes, if some of you have forgotten what the rubber dam looks like from dental school, I'm going to encourage you to get all those supplies back out. I'm going to remove biofilm. I'm going to, sometimes it's may hard to do this, but I'm going to take my chemistry hat off. Now, don't get me wrong, chemistry is important, but I'm going to put my engineering hat back on tonight. We're going to discuss why prep design is so quintessential for having long-term success for your posterior composites. I'm going to use a matrix actually shaped like the tooth. Why it took this long for someone to develop a matrix that you could cure through that actually looked like the tooth, it's beyond me. And I want to mimic that shape of the natural tooth if it's at the junction of occlusal middle third. And I need to get that light all the way through. If you think with a metal matrix that those photons are getting down to those camphor-quinones and all the other components of your composite that give our photopolymerization, you are wrong. I see it under the scope all the time. I use very high magnification often when I work. And when you take that metal matrix out, we have the ROB, often the river of blood. And often that light is not getting down to the very base of our preparations. I want an emergence profile that starts from the gingival attachment, and I want a wedge that is wider than taller to use. If you noticed earlier that restoration had pinpoint contacts in the occlusal, often that comes from needing to use a wedge that is large, and the spine or the top of that wedge is driving our contact to the occlusal third, last place where I want it. And I want to use a ring that properly separates to the teeth. And tonight I'm going to be showing you the composite that I've used every day, every single day of practice for the last, I think, 9 years now plus. We're going to be using Solventum's Filtech 1 composite. We'll go into detail earlier. All right, again, prescriptive. Everything I'm going to show you tonight is available online. This is step-by-step instructions how we restore teeth. There's a lot of little steps, I get that, but there's a lot of recorded presentations that go through this if you go on YouTube, or we'll make these available for you. So this is what I'm going for with a clear matrix and proper prep design. If you think about on the holidays, you may have a piece of pie and you cut out that piece of pie. When you put that piece back, that's what we get with GV Black Dentistry. We are literally cutting a box and trying to just shove that material back into the tooth. That may work for amalgam. I promise you it is not set for composite-based dentistry. If you look at all this F word, the flash around the tooth, we don't see this on a daily basis, but this is what happens with composite. Composite does not want to be marginated. It doesn't want to be put in a box that's 90 degrees. This is what the ideal for all of my preparations and my restorations is I want to now wrap or ensconce that restoration somewhere around the buccal, somewhere on the lingual or the palatal. We just don't see that microleakage when you have boxy preps like this. I want to spread that shrinkage stress. I don't care what composite you use, even if it's an amazing composite like I'm going to show you tonight, that's a bulk cure. All composites shrink. If we grab 70% of that enamel and minimize the amount of dentin that's exposed, we have much higher chances of not having post-op sensitivity, putting our tooth in an area where those quote-unquote margins are cleansable and it's comfortable for the patient to floss. I showed you this earlier. This made no sense to me. Why are we cutting boxes and putting them in the exact place where that patient could not keep their restoration clean? But what do I have now? That word margin is out of my vocabulary. We have a TRI, a tooth restorative interface. If you've seen drywall, maybe when your offices were constructed, they took that drywall mud and they put it on the wall and they thinned it out. That's exactly what I'm going to show you tonight using heated injection molded composite. And I want your embrasures to look like teeth and be cleansable. So let's show you one clinical case. This is Dr. Clark's case through the inventor of Bioclear. One quick pearl. Before you start restoring teeth in the posterior, especially if you're restoring multiple teeth at one time, I would highly suggest checking occlusion, snapping intraoral photos so you see where all your contact points are. This is a rubber dam that I switched to about a year ago, and I can never use another rubber dam again. It's absolutely my favorite. I'm not sponsored by Dam. They don't, but it is by far my favorite. And if you have not tried Gorilla Floss, that may be worthwhile tonight, just learning about it. One of my colleagues, Patrick Ruck, turned me on to Gorilla Floss. It does not shred. It does not break. It's the perfect thickness. You can get it on Amazon. This is the only floss I will use now. So there's our preoperative bite wing. We're going to restore a carious lesion on the distal of the second premolar. There's our lesion, a little bit into dentin. Rubber dam is placed. We are going to pre-wedge every single time, multiple reasons, but I want to push that rubber dam down. I want to protect my soft tissue. We're going to start our preparation, and we'll go into detail on this later. This is a non-retentive class 2 preparation where everything is rounded. This is what we call a radius bevel. I have a gingival bevel here and selective caries retention when needed. For all of you that are pediatric dentists on tonight, you know about modified Hall technique. Every single dental school in North America is teaching selective caries retention. If it's something that you're not familiar with, I highly suggest doing research. We're going to use a probe to actually measure both for depth of cure and for the height of the matrix. These are the three matrices that we'll be using molars tonight. The black is a premolar, blue for basic, or blue for the most, I would say, average shape of a molar. That's the molar matrix we're going to be using tonight. And then the orange there is for a little bit more of a broad contact. So there's our matrix. Now, what's the advantage here? Number one, it is clear you could actually cure through it. Amazing. Why did it take someone that long to figure this out? It's shaped like the tooth, and that contact is sitting exactly where it's supposed to be. These are diamond wedges, and the diamond wedge, you can see the wedge shape there. It's designed to lock into place and help us not have a spine height that's sitting in the middle of our contact. So there's our setup. Our twin ring rubber dam is placed. What you'll notice here is our matrix slightly sits off the tooth, except in the areas that are engaged by the retaining ring, that twin ring. I want some space there. If needed, we'll use an instrument to make sure that we have a tight contact. We injection mold, disc, magic mix, which is a pre-polish, and then a Rockstar polisher. Now, that's the result I want to see every single time. My TRI is somewhere here. My TRI is somewhere here. And what's more important is this is a 3. Now, I can show you much longer follow-ups, but this case, that's a 3-year follow-up. You see you have no ditching at the margin. There's no staining. That tooth looked exactly like it did as soon as it was finished, okay? And we can take dentistry that unfortunately looks like this, and I want to fast forward a little bit here just to show you before and after. But unfortunately, this is what we see every day. And this goes into more detail about the prep design. Those are our clear matrices, our twin ring, and our wedges. But most importantly here, what I want to show you is that's after. Okay. So we went from blocky contacts, likely there's still caries there, contacts that are probably almost impossible to floss. And that's what you see with injection molding with a matrix actually shaped like the tooth. And you saw the results earlier, 3 years. If you want, email me. I will send you 5, 6, 7, 8, 9, 10-year results. So let's really get into modern prep design. As you see our tooth there, it's a 3D rendering. Here's all the things I need to think about in my head. I want a prep that's not this. That's 90-degree GV black, correct? That's what we were taught. So I want the opposite of that. I want a prep that's designed for composite. I want to minimize the amount of stress internally and externally on that preparation. I want to grab as much enamel as possible, and I want everything to be compression-based, meaning that when that patient bites, I want them to hit perpendicular to that occlusal surface. So that's GV black, and that's what I want to get away from. So where's the change, right? We're getting away from these 90-degree butt margins, and all the way on the right, that's what I want you to think about. Everything is round, everything's a radius, everything is compression-based. We need to change the way that we think about our prep design, also not only based on engineering, but based on cariology. When GV Black designed those preparations, he wasn't thinking about teeth that have massive amounts of flora on the outside, but are soft in the middle. And unfortunately, with these 90-degree butt margins, we are literally sitting our 90-degree preparations into caries and decalcification. And if you need to widen that preparation, you're going to wind up undermining cusps, right? Our composite is extremely strong in compression. What does compression mean? Again, it's like a spring hitting 90 degrees to that occlusal surface. Tension is pulling cusps apart. Every time this patient bites, when you have a 90-degree butt margin, we are degrading the bond between that restorative material and the tooth itself. This is a concept I want you to think about. Compression is like a spring. I want, as much as possible, think about why a sealant can last so long on a tooth, but you may have done place a composite and it's fractured over time or debonded. Every time that opposing cusp hits, I want to think about hitting perpendicularly, like a spring, compressing that restoration down and not pulling cusp apart or pulling that restorative material away from the tooth. If we look at, these are 8 of the most popular composites on the market, look at that. They're 4 to 5 times stronger in compression than in tension. These are things I think about every single time I prepare a tooth. That's tension-based, right? Every time that patient bites, we're pulling cusps apart and we're debonding our restoration. We're going to talk about the calloli tonight. Very quickly, what I want to remind everyone is caries doesn't just laterally move into the tooth. As we move through the interstitial spaces between, especially in our dental rods, that caries lesion is heading down on an angle. And so if we prepare a tooth with, I'll show you tonight, making sure that we remove caries of the DEJ, we don't have this. This is GV black 90 degrees, and this is why, unfortunately, so many teeth have pulp exposures. This is the basis of everything we're going to learn tonight. 1 to 2 millimeter gingival bevel, caries removal, complete caries removal, I should say, at the DEJ, and we are staying away from the pulp. We're practicing selective caries retention, and as we get to our occlusal or our periphery, everything is radius, everything is round. This is an example of the final prep that I'm going to show you guys tonight, and everything is radius, everything is around. 1 to 2 millimeter gingival bevel, complete caries removal at the DEJ. I've got a 1 to 2 millimeter radius bevel. What does that mean? That is a continuous bevel going from the DEJ to that occlusal surface. This is not an accurate term, but I want to occlusalize my preparations. As I come up to that occlusal surface, I want to be tangential and then just flatten out as much as possible, getting on that occlusal surface so my restoration stays in compression. Now, just to clarify, I don't want this to be flat. This is a radius. This is a long bevel that is convex, and I'll show you the burrs that we're going to use tonight to make this easy. What I'm most excited about, the burrs that I want to show you tonight, and I didn't mention this earlier, I have signed away all of my financial rights on anything having to do with these burrs. This has been a passion project for me, and I just can't talk about them, educational basis with making any money. So I do not make a dime off the sale of these burrs. It was a big deal 4 years ago or 5 years ago, or how long we started this process, to start to reinvent the fissurotomy burr. SS White brought these burrs to market. These burrs were, I think, first designed back in the even the 50s or 60s. I'm not sure that date, but it was a long time ago. And we've made some important changes to this fissurotomy burr. Number one, you see it's rounded or cavalierly shaped. Number two, if you look at the end of the burr and it's a single blade, what we found is a single blade actually stays much more sharp than multiple blades. And these burrs specifically are lightly end cutting. I don't want to go in with a selective caries retention burr or a minimally invasive burr and have it bury down deep immediately into the teeth. So they're very sharp on that radius or round, but you have to give them a little pressure for them to cut on the very end of the burr, and that is on purpose. That's on purpose. So these burrs come in a kit. There's 3 main kits. You can buy refills for them, but there's an introductory kit that is just the cavalierly shape, both carbide and diamond. Then there's the kit that's really meant for people only restoring permanent teeth, and a pediatric class 1, class 2 kit. And again, I don't make a dime off the sale of these burrs. It's just something that I'm passionate about. And you can scan there on the QR code. You'll see this a number of times tonight for more information about these burrs. So there are 3 diamond burrs, 3 carbide burrs. The diamond burrs have that rounded cavalierly shape. I know this looks big. We'll talk about what that burr is. And then the carbides, this first cavalierly carbide or a super narrow is really meant to replace the fissurotomy burr. And then for more just straight occlusal caries, we've got a slightly larger burr. And then for large occlusal caries where you've got dentin involvement and you really need to make sure we have a round radius or a cavalierly or a trumpet shape, that's the larger carbide, and we'll go through each one of these. If you don't know what a cavalierly flower is, I didn't know what it was 10 years ago. Think of it also as a trumpet. Everything is round, everything is a radius. Now, the idea of that cavo surface being 120, 130 degrees, this isn't something we came up with. If you want to hang out with a fun group, you can hang out with everyone at the Journal of Mechanical Behavior of Biomedical Materials. But to be serious, this is quintessential in how we prepare teeth in the posterior and the anterior for composites. Everything's a radius. Everything is round. I need to open up those enamel rods. I need to have a large surface area of enamel adhesion. I want to minimize the amount of dentinal adhesion, and I need to keep this tooth in compression. As that patient bites, I don't want 90-degree butt margins like you see here. If you want to break composites and debond teeth, tensile forces is a great way to do it. So what does this look like in the mouth? So we're going to take a GV black 90-degree 56 burr, run it through the tooth. That's the last thing I want is these tension joints at the primary strike point. What does that mean? Every time that patient bites, if you cut 90-degree margins like this, you have a 90-degree interface between the composite or amalgam or GI or whatever, RMGI, whatever restorative material you're using, to the tooth surface itself. That's the best way to have debonding. That's the best way to have microleakage. That's the best way to have fracturing. So what do I need to do here? I need to sacrifice a little bit of enamel. I promise you'll be okay. If you worry about taking out way too much tooth structure, I'll show you micro CTs. This is no more tooth structure reduction than we did with GB Black. It's just in the right places. So everything's a radius, everything is a round. I have a smooth, continuous bevel from my DEJ, and if I need to, I'll go just shy of my cusp tip. I don't do that every single time, but if I have a large occlusal lesion, I'm going to spread those compressive forces over as much enamel as I can. So how do we do this easily with a burr that's actually shaped like a calla lily or a trumpet? It's rounded. I don't want to make a lot of burr movements with my hand. If I use a flat or tapered diamond, I can really over prep or cut planes. If you think about enamel, we want to expose our enamel rods at that 130 degrees, 120, 130 degrees. We have a burr that's actually shaped like that calla lily, and we're just removing enamel at the primary strike point from my DEJ, and if I need to, at my cusp tip. One important point tonight is that the composite we are using for Filtech 1, this is a bulk fill or monolithic injection molded composite. I've got 4 millimeters of depth here from the occlusal, 5 for a class 2. And I don't want to cut away deep grooves in teeth. I need to keep at least 2 millimeters of composite over my dentin to keep this tooth in compression. Again, that's the prep that I'm going to show you live tonight. I want to show you some examples of the 3 burrs, the carbide burrs in the system. And the first burr is this super narrow carbide, calla lily carbide. It's really meant to replace the fissurotomy burr for stain grooves. We used to call them PRRs. We don't do that anymore now. There's CDT code changes. But this is for if I'm going to use sealant or a flowable material only in enamel, this is my burr of choice. Then I go up one size. This is now my CLF burr. This is for caries that are just through the enamel or maybe slightly into the dentin. And you can see here that we are just opening up the radius. These burrs are extremely sharp. They're lightly end cutting, but they're meant for side cutting to make sure that we're not removing more tooth structure than needed. And that's the big guy here. This is our CLF burr. This is for large occlusal caries. If you can see how clean that calla lily shape is, I don't have to go back with another burr and refine this. I want one burr that cuts quickly and efficiently, and this is the burr to do it. Okay, so you can see this is just an extracted tooth that I used all three burrs on for the calla lily carbides. And so super narrow, and then the CLF is what I use the most because I find honestly many teeth have some occlusal caries. And then if you need to remove larger dentinal caries, a larger lesion, then I'm using the CLF burr. And one of the other reasons why we shaped these burrs we did was with a standard fissurotomy burr, it's very easy to cut a channel that you cannot get the tip of your flowable through. And you get these inclusions inside your resin. And sometimes they're going to be okay if they're inside the resin itself, but it's definitely not something that I want to see on my radiograph. Let's talk a little bit about the restorative materials we're using tonight. I can no longer use room temperature composite. If you hand me the composite dispensing gun, I wind up breaking it half the time because I'm pressing too hard. I want to highly reduce the amount of extrusion force, and I get that by warming my composite or composite if some of you are in Canada or other parts of the world. With 3M Filtech restorative materials, the universal composite, our Filtech 1, or our Filtech Supreme Plus, Ultra Supreme Plus, thank you very much. All of these materials can be heated. Solventum was the very first company to get FDA clearance to heat all their line of composites. And I promise you there was unbelievable amount of testing. I can send it to you if you want, or it's available online. It does not change the bond strength, doesn't change the color stability, the tensile strength. And the main thing I want to do here is decrease that extrusion force. Now, how do we heat composite? In my dad's days, he either held it up to a light or I think at one point he had a coffee warmer to heat his composites. Not the most selective and appropriate way to do this. There are less expensive. You can buy things on eBay. Not my first choice. So the two warmers I use in my office, one is made by Bioclear, one is Solventum, and I think they both have a place in our restorative acumen here, in our armamentarium. The Bioclear warmer allows me to have multiple syringes of flowable and multiple syringes of paste, or our heated Compules composite. The Solventum Filtech warmer is smaller, heats up a little bit faster, but it's less expensive. And if you have many operatories like I do, that's a good choice for you. I find most doctors that are, restoring teeth like I do have, 2 or 3 Bioclear warmers, and all the rest they have Filtech warmers. And there's deals online for these if you buy a certain amount of composite. We're now going to be using tonight. We're using Scotch-Brine Universal Plus. If you haven't seen, this was updated a few years ago. They increased the silane concentration and a few other components, but highly radio opaque, has a low film thickness, and I use this for all my restorations. So this is the material we're going to be using tonight. This is a bulk fill, although I like the term monolithic. I just think it sounds more scientific. Again, 4 millimeters depth of cure from the occlusal, 5 class 2 if you're using a clear or a Bioclear matrix. In the posterior metal, you need to stick to 4 millimeters. Okay, it comes in a flowable and in paste. And one of the amazing components of this is the amount of depth of cure, and the opacity changes. It looks a little bit more translucent when you go to restore teeth, or injection mold. And as soon as you hit it with the light, that B1 is incredibly opaque and aesthetic. And I talked to you about this tonight. All right, we're going to go over to the scope before I go back. And we're going to spend the rest of the night, besides the wrap up here, on under the microscope. So I'm going to hit stop share there, and I will unblur my background, and let's go to the microscope. There we go. Okay, so we're going to restore tooth number 3 tonight. That's the 1-5 for those of you outside of the US. And the first thing I'm going to do is put my pre-wedge in. My pre-wedge is going to enter into the side where my embrasure is the widest, which here's on the palatal side. Pre-wedge in place. I want to show you both burr kits that I'm going to use tonight. So this is our carbide burr kit. Again, this comes in pediatric or adult. The difference is I've got a pediatric here. It's just the adult one has more of the cal-lily carbides in place, and those are all our cal-lily carbides. So you can buy these as refills. You can buy these in a kit like this. This kit has 2 of each of the carbides. So there's 3 carbides and 3 diamonds, but you get 2 of them in this block. So these are our 3 carbides, our cal-lily carbides, and our 3 diamonds. Again, for fissurotomy, a little bit larger caries, and then way in the back, large caries. So I'm going to, out of our class 2 burr block, I'm going to grab the 018 burr, and the 018 burr is definitely my workhorse burr. And the very first portion of my preparation tonight, and I'm going to prepare this teeth pretty quickly because I also want to get to restoring. I'm going to come in at about a 15-degree angle, and I'll use a little bit of water here. And the reason why I want to come in at a 15-degree angle, let me do this first, is I want to just see the end of my wedge. If I can see, if you just turn the scope here, you can see I've exposed my wedge. The reason why I do that is because I want to know that I'm actually underneath the contact, and I can make sure that I've removed all my caries. Then I'm going to go to more thin burr, and this is it's a more of a flat taper diamond. And what I'm going to do here is I want to just simply break my marginal ridge. And if you go on YouTube, we have videos start to finish of this preparation. And all I want to do here is just remove that little bit of marginal ridge. I'm going to take my pre-wedge out. Then I'm going to go to one of my diamonds. And if we look at all 3, we have 3 of the cal-lily diamonds. I'm going to go with the smallest cal-lily diamond at first. And I'm going to use the shape of my diamond here to give us that cal-lily shape. Everything is a radius, everything is round. If you notice, I'm having to do very little movement of my hand. I don't want to have to roll. I want to have that calloly shape, that 2 to 3 millimeter gingival bevel built into the burr itself. Okay. Then, if I have more caries, I'll go back in with my 018 burr. Again, this is the workhorse burr out of my kit, and it's on the upper right there. And if I have a little bit more caries, now I'm going to do some selective caries retention. This is my caries pocket removal, but I really want to make sure that I am fully removing all the caries at my DEJ. Sometimes underneath our cusp, we have some caries as well. And then I'm going to start just removing any little bits of unsupported enamel. And then lastly, I want to go ahead and take that same burr that I used, that thin diamond, and this is going to give me my 1 to 2 millimeter gingival bevel. Everything is round. Everything is a radius. Any areas where I have little stress risers or small areas of unsupported enamel, what you're going to find is once you get used to this preparation, it is much faster than GV black. I'm not worried about 90-degree butt angles or trying to get a wheedle set out, right? So let me dry a little bit here. And that's generally what my prep looks like. Now, there are other burrs in the kit for smoothing composite. Again, I will show you next. We're going to go ahead and I want to simulate, let's say my typodont here had a little bit of occlusal caries or more stain. I'm going to go ahead and grab, I've got two choices, either my most narrow burr, my narrow calloly carbide. I'm going to go ahead and grab the middle one here, which is my calloly carbide, my CLF, NCLF burr, or CLF burr, excuse me. What I want you to notice is that if I press down apically, it will cut as end cutting, but very quickly, I want you to see that radius that's built in. I don't have to move my burr on an angle. And this burr actually on purpose, I've sterilized, I think 3 or 4 times already. Now burrs, of course, you know, they're truly meant to use once. But this tip, you can see it's actually dark a little bit. I did that on purpose. This burr I've used a number of times already because I want you to see how effectively and efficiently this cuts. And that radius, and I'll dry here in just a minute. What I want you to notice is that calloly shape is already built in. Everything's round, everything's a radius. And you saw how efficiently this cuts. Now let's pretend I've got caries that are a little bit deeper or wider. Then I'm going to grab the largest burr out of the set. And they are all labeled for you here, which is really nice. Our NCLF, which is our super narrow, then our narrow CLF, which is the NCLF, which is the middle. And then I'm using the larger of the carbides. This is our 1, 2, 3. And this is our third in the set. And this is our dentinal caries caliber, our large occlusal caries. And this is, you know, you've got large caries into the dentin. And again, I want to show you just how efficiently this burr cuts for us. And let's do that next. I'm putting very little pressure down with this burr. Now, if I want to cut apically, I'll put a little pressure down. Again, that is designed in this burr. It will end cut only if I want it to. But where it's going to give me is that round or calloly shape built in. And I'm moving pretty quickly here, and this burr is catching up with me. Everything is radius, everything is round. I have a convex bevel going from the dentin to our most occlusal portion of our preparation, okay? Now, tonight, again, I wanted to show you radius, 1 millimeter bevel, selective caries retention. We're not going to restore a tooth tonight, but I do want to show you with a matrix that's shaped like the tooth, just because of time. So I'm going to go ahead and put a 6 millimeter Evolve Bioclear matrix in. And then I'm going to place another wedge here. And before I used our medium, I'm going to go up to a large. Now I used a large. I'm going to grab that large again. Pressure. I'm going to sweep underneath our contact. And if you look laterally, remember, I don't want to be an occlusodontist. We're going to that's the exact shape of that tooth. Then I can grab my twin ring. Oh, we've got plenty of time to restore. Great. I'm going to hold that tab down. Okay. Then if I need to, I'm going to take my push-pull instrument and I want to judge if I need to use an instrument to close my contact. I'm great there. I'm not going to etch tonight. I just don't want to make a big mess here, but I would etch, rinse, and dry for 20 seconds. After I've etched, rinsed, and dried, I'm going to go ahead and grab my Scotch Bond Universal Plus. This will be the adhesive I use tonight. We are going to scrub into the dentin for 20 seconds. 20 seconds is not 10 seconds. It's not 5 seconds. I put just a little bit of adhesive on my micro brush, and I'm going to scrub into the adhesive for 20 seconds. I don't want to waste your time tonight, so we're going to call that 20. I'm going to air thin. If I needed to do something called spot welds, which is to put a little bead of composite here and here to pull this matrix over and tack weld, I will. Right now, I've got a great contact, so I'm not going to be worried about that. I'm going to go ahead and grab my light. Tonight, I am using my 3M Epilar Deep Cure, and I'm going to go ahead and cure for 10 seconds. We're going to speed it up a little bit. Now, what's my next step? I'm going to take a mop brush. Again, this is my mop, and I'm going to coat the entire intaglio surface of my matrix and the tooth. Now, this is where some of you may get a little worried. I'm going to air thin, do not light cure. My dentin is cured, but I do not need to cure over my enamel. So I'm going to air thin. Then I'm going to take my heated flowable. So this is my 3M Filtech Bulk Fill Restorative. I'm going to use A1 Flow. That's the lightest shade they make because B1, it would be translucent. If you notice, I'm going to walk that flowable with my cannula tip circumferentially around my preparation itself. Now, the goal here is not to fill this cavitation with flowable. All I want to do is coat the matrix and coat the tooth. My adhesive becomes my initial bonding layer, and then my flowable really is acting as a carrier. Then I'm going to use my paste composite, and I'm going to slowly inject, and I'm going to turn. And what you see here is I'm actually pushed out all my excess adhesive and flowable. So this restoration is almost 100% paste, right, which is our injection molded and heated composite. If I need to, I can take a dry brush. Now, I don't want to over-instrument this. I'm going to grab a C3, and all I want to do is give myself about a 1 millimeter central groove. I want to leave at least 2 millimeters of composite over dentin to keep this in compression. I don't need to spend too much time putting anatomy in here. I'm going to cure 10 seconds from the occlusal. And I take my twin ring off. 10 seconds on both the palatal and the buccal, or if you have two lights, you can do this at the same time. Now, I'm not going to finish and polish tonight, but what I want to show you is the magic of having a matrix that's shaped like the tooth and an injection molded composite that's warm that you can cure through with 5 millimeters. I'll go ahead and take my boom. And what I want you to see is I don't have to worry about doing very much finishing and polishing. This Mylar finish is going to be better than any finishing and polishing you can do by hand. I've got a contact at the junction of the occlusal middle third. I have very little finishing I need to do with my composite. All right. We didn't talk about light curing tonight, but it is quintessential, of course, for light cured materials. For all of you that are on tonight, what I beg all of you to do is call your Solventum rep. They will come in with it's a different radiometer than you're used to. It's actually Bluetooth connects to the computer. It will test the depth of cure and the wavelength of any material that you use in your practice, just not Solventum lights. They will put a barcode on it, and I cannot stress that enough to have your lights checked. Please, please, please.
Actually, what we're going to do now is I'm going to take some questions from our audience. We have a couple of them in the chat. Our first question is, what carbide burrs are you using to prep the class 2?
So great question. So so we have 3 carbide burrs. I'm using diamonds initially and I'm using electric handpiece. So I don't use a lot of carbides except for caries removal, opening the grooves in that calorie shape. So the 3 carbides that I showed tonight, those are the carbides that I use in my practice. That tunnel that you saw initially for the class 2, that's with one of our diamonds, and that's in the 2 kits, either the pediatric kit or the adult class 1, class 2 kit, and that's an 018 diamond. In the pediatric kit, we have an 018 and an 016 that we give because sometimes for smaller teeth, that 018 can be a little big. But I don't use a lot of carbides except maybe for finishing. But most importantly, as we discussed tonight, are calorie carbides for caries removal, for beveling, for creating that calorie or trumpet shape.
Okay, and next question. Do you prep the same way when using Stella Composite?
Exactly the same. Yeah, composites, GI. All my prep designs are going to be the same for adhesive dentistry. Great question.
Do you also use Filtech bulk fill for pediatric?
I do. That's the only posterior composite for all my class 2s. Once in a while, someone mentioned, Stella, I'll use that sometimes for my larger, really hypoplastic where I need an auto cure composite. But I would say 85% of the restorations I do on a daily basis, primary or permanent teeth, whether small class 2s or giant cuspal overlays or stainless steel crown alternatives, is all with Filtech, with bulk fill 1.
Do you use Bioclear matrix for pedo teeth?
100%. Yeah, I have not used. I don't know what I would do with a metal matrix anymore, but yes, absolutely. And that's one of the things we teach. I showed you. You saw some examples tonight of primary teeth. And if you go on to pediatricdds.com, I have some examples there of what clear matrices look like. They actually look like teeth. They're not big blocky contacts to each other.
Next question. Sorry if I missed a step, but do you place the adhesive bond on the tooth twice?
We did. That's a great question. First step with our adhesive is our dentinal bonding. Remember, we want to plump up those dentinal tubules. And then if needed, I will put a little bit of adhesive on the periphery of my matrix, and I put little spot welds. I didn't show you that tonight. That's just another step that we do. And if you go to bioclearmatrix.com, you can download that guide, but there's many videos online. So I'm putting adhesive down first to just for my dentinal bonding, and then also my spot welds if needed. I cure, and then secondarily, we're putting adhesive on that whole intaglio surface of the matrix and over my entire preparation, air thin, flowable, and then paste. I promise you all 3 will be absolutely fine. But again, in enamel, not with dentin. Dentin needs to be cured separately at first.
Do you micro etch aluminum oxide 27 microns right after making the prep before selective etching?
That's a great question. So there's 2 things that I utilize on a daily basis. Number 1, I use the blaster, and we talked about that tonight. That's this device here. So this is aluminum trihydroxide. I will use this to pre-clean the teeth, and then right before I put my matrix in, I will blast again. But also something that I use on a daily basis is air abrasion, and that's actually to cut tooth structure. So this is aluminum trihydroxide, aluminum oxide, which I also use on a daily basis. I use that to cut teeth. So if I'm not using, but if I don't necessarily every single tooth, I'll use aluminum oxide, but I use the aluminum trihydroxide and that Bioclear blaster on every single tooth. Sealant, class 2, occlusal, doesn't matter what it is.
What do you think about the 3 seconds light curing gun?
Yeah, I'll tell you one of the problems, and I have a high-speed light here in my office. I will tell you anecdotally that one of the issues that I have, no, don't get me wrong, I think there's some valid science behind the laser lights that are laser-based. One of the problems I have is when my assistant brings over the light, often they will hit and press the button and push at the same time. And so the way that we work, our protocol is we turn that light on slightly away from the tooth and then bring it over. I start running out of time. So it's laser based. There's more and more data coming out that these fast laser curing lights have a lot of validity to them, but I'm using a 3M light, 10, 20 seconds for all my restorative materials. The most important thing is follow the IFU. If Solventum wanted you to use a 1 second light all the time, they would put that in your IFU. I would suggest contacting any manufacturer that you're using their materials and ask them that question. I want it to come from the research scientists, and so they will tell you what's appropriate to use for their material.
Where do you buy your rubber dam from?
Rubber dam can be any Shine, Patterson. I buy all my things from Shine. You can just get them from any of the major houses. I think probably 90%, 95% of my materials are either from Shine or from Bioclear.
What do you use to polish these at the end?
Yep. At the end, it's that we discussed it very briefly in the beginning. So it's Magic Mix, which is a pre-polish. It's 3 different grits of aluminum oxide. And then as needed in the posterior, I will then use a Rockstar polisher dry, which is a diamond impregnated cup, and then a Rockstar polisher wet. I find in the posterior, sometimes I only need a brownie unless it's, it's a big composite overlay or, large multi-surface composite on permanent teeth. The interior, I'm using Magic Mix and that Rockstar polisher dry and wet every single tooth without fail.
Have you used air abrasives to prep without the use of a hand?
Every single day of my life, 100%. That's a whole other webinar I could give, but I've got 3 or 4 different units in my practice, and I use it every single day almost for a vast majority of teeth. I'm using carbides, diamonds, and air abrasion.
For primary teeth, are the steps still pretty much the same?
Exactly
Are
the
there
same.
different matrices for them?
There will be pediatric specific matrices, but what we use now is one for the primary first molar. I use a 5 millimeter evolved. It's the black matrix. I cut it down to 4 millimeters. And then for primary second molars, actually use the BioFit, which is the Bioclear matrix that is the generation before the current ones. I just like the shape on that one for ease, and that's a 4.5.
Why didn't you light cure flowable first before placing the composite?
Good question. The flowable is just a carrier. So we cured our adhesive over our dentin, and then adhesive again is both our enamel wetting and adhesive agent. It's also the carrier for the flowable and the carrier for the paste. It's 1, 2, 3. We've tried, and I'm sure many people have tried to get away without using flowable. You can sometimes do it, but I need that flowable to be that carrier and help me carry that paste composite or heated compulse composite circumferentially around that tooth. You have to think about, we are extruding that composite sometimes 6, 7 millimeters around the quote unquote margin of our preparation. You've got to use all 3 to have prescriptive results every single time.
Are there any time you don't remove the marginal ridge, a tunnel?
It's dependent on I do that on purpose. That is by the first step for a reason. When people take a 56 burr and just come a marginal ridge straight down, I find what happens is they don't deepen their preps enough. And so often, instead of being apical to their carious lesion or apical to their decalcified enamel, they are sitting still in the middle of their caries. The other thing that happens, it's very easy when you prep buccal lingual or buccal palatal to widen your prep. I want to keep that bulk of those cusps, we call them the shoulders. And trust me, when I first learned to do the tunnel, I said, I don't really need to do that. I'll go back to my other ways. And then within a very short time, I went back to tunneling. It is our most prescriptive way of removing that, having the base of that preparation exactly where it needs to be, apical to where your decalcification is. It just sets the tone for that entire preparation.
Do you micro etch before, after a Vitrobond or Activa base in decays?
Yeah, I don't use a lot of bases in my practice. I'm probably the last guy to ask. That's a whole other webinar. But again, we're not micro etching. We're using that blaster with aluminum trihydroxide, which is only the hardness of dentin, or actually a little bit less, before we put our matrix in and restore. So I'm not worried about cutting dentin with blasting. Blasting and air abrasion are 2 totally separate things. They're related, but the aluminum oxide is 40 times harder than aluminum trihydroxide. So, but to answer your question, you would blast first with aluminum trihydroxide, remove the biofilm, remove the smear layer. If you are using a base, you would put your base on and then start your etching and adhesive steps.
How do you keep that flowable from expressing out of that gingival bevel? The wedge
It
sometimes will
is.
not
Great
keep that
question. I
in.
get asked that all the time. Your matrix is sealed by the gingival attachment and the rubber dam. Now, can you do this without a rubber dam? Yes, I highly recommend it. But it also has to do with the thixotropic nature of that heated flowable. It becomes so flowable, that flow becomes so flowable that unless you are trying, you bury your tip as apical as possible, you're not, they're worried about having a blowout. It just does not happen. I've never had that happen once actually in any of my my restorations. That matrix is shaped with that curve past your gingival bevel, and your gingival attachment seals it against the tooth, and your wedge and the rubber dam seals it. If you use heated injection flowable and then paste, you will not have that problem. I understand why it's a worry,
How
but it's not a thing. I guess it could be
how
if you're.
about oh,
Go
sorry.
ahead. No, go ahead, Sophia. Thank you.
How about dry shield isolation?
Do I use that sometimes? Yes. Occlusals, yes. The problem is a rubber dam, it's not going to do what a rubber dam does. It decreases the amount of bleeding. It pushes that coal area of our interproximal gingiva down. It not only protects the soft tissue, but it also exposes our decalcified enamel. We know that the bond strength of decalcified enamel is almost nothing. It's almost nothing. And so I need to push that soft tissue down. If I get a properly placed rubber dam and a matrix that's selected properly and my twin ring in place, that is my sweet spot. I spend more time actually getting my dam on and my matrix selected, my ring on, than I actually do injection molding the tooth, because that matrix becomes our anatomic tooth form or our wax up. It's the exact shape of our restoration. So can you use dry shield or an isolite? Yes. Can you do this without a rubber dam? Yes, but my preference is always to use a rubber dam.
We have about 4 more questions. Are you good with that?
I'm fine as long as you are. I know we called it for an hour, but if you're okay going a little bit over, so am I.
I think so too. I think some of these are
Okay,
really good questions coming
great.
up.
I'll stay there all
Can you
night if you want, but you probably want to cut it off at some point.
Okay, can you do a deep margin elevation with the Bioclear matrices, or how do you
100%.
manage
These
deep?
go, yeah. So if you just Google deep margin elevation with Bioclear, these matrices will go up to 9 millimeters tall in the posterior. Um, Deep margin elevation in the adult world is something that's done every single day with these matrices. They are designed for that. We talk about having an apron. So the 5 millimeter matrix is kind of the shortest matrix, but we go all the way to 9. And the beautiful thing about it, a 7, 8, or 9 is the wings or the circumferential portion of that matrix will sit supragingival, but that 9 will sit 1, 2, 3 millimeters subgingival. And it's designed for that reason, either for fracturative cusp or deep margin elevation. That's something, in the 4-day course we talk about in detail.
Okay, and how do you remove flash?
That's a great question. That F word does not exist if you're blasting and you're using heated injection molded composite. We saw tonight that with heated injection molded composite, there is no minimum thickness over enamel as long as it's not like on a cusp or incisal edge. So just like we did with drywall mud, we go from thick to thin. We have that TRI or that infinity edge where I can't even perceive or feel the periphery of that restoration. It's only flash if you don't disclose and blast and use heated injection molded materials and using a clear matrix that's shaped like the tooth. If you try to do this with a metal matrix, often you're going to have the F word, which is flash.
Do you ever use the bonding agent from Vocal called Futura Bond?
I have not used, I try to keep a recipe, right? The story I tell is, my grandparents came over from the old country with their bread recipe, and I don't want to ever change it because I know it's perfect. And if I start changing things, I might have a mistake. So there's a lot of good composites on the market. Vocal makes good composite, but it's just not part of the system that I use. And I try to keep everything prescriptive, 1, 2, 3, ABC. But like I said at the beginning of the webinar tonight, is that there's a lot of good materials out there. There's a lot of good manufacturers and materials. I use what I use because I know they work. I use them on a daily basis. I know the research behind them. But that's something where if it's part of your armamentarium, you can always try that.
sonic fill system versus heated composite? What is the
Well,
best to
I used
use?
Sonic Fill for a lot of years, and Sonic Fill was actually it was kind of a step into using heat injection molded composite. It uses the same cable coupler that's on our blaster. But if I want to really control the thixotropic nature of that restorative material, I want it heated. The problem with Sonic Fill is once you stop sonicking it, that's not the right word. Once you stop, sonically vibrating the material, it stopped flowing. And for just a GV black preparation, I think that's probably okay. But I need that composite to stay warm so I can inject and move it around corners. Can't do that with a room temperature composite. Or I should say it's more difficult to do with a room temperature composite. I don't have good success with room temperature composite showing you the steps I did tonight.
Any discount code for buying the burr kits?
If you go, I don't know. I stay out of the sales portion of this as a clinician. As I mentioned, I don't make a dime off these burrs. I probably wasn't the smartest financial decision I've ever made, but I can't talk about things in a scientific meeting if I'm making any money off it. But if you go follow the QR codes that we had tonight and any follow-up emails you get, you will see either on from SS White or directly from Bioclear, you'll find those burrs. And I tell you, I do know they price them very reasonably because they want to get them in people's hands.
Okay, one last question for the evening.
Please.
With the gap at the gingival margin, how do you not get any overhang? Can you
No
expand
gap
on
in
that?
the gingival margin. Sorry, I got all excited, Sophia. Sorry. There's not a gap in the gingival margin. That is a slight space from the periphery of your gingival bevel to your sealed Bioclear matrix. So that's the whole point of using heated injection molded composite. I need to have that flow, that laminar flow of material to go past that 90-degree bevel that we saw with GV Black. And I need to have that flowable, my adhesive and flowable paste to go past that gingival bevel and it be sealed at that periphery of that matrix, which most of the time is 1 to 2 millimeters sub G. That's a big deal, right? That's a big deal. We're no longer cutting boxes and marginating to that. If you noticed all the restorations I showed you tonight, there wasn't flash of that gingival bevel. I can send you hundreds and hundreds and hundreds of x-rays if you want. This is all I've been doing in posterior for, I don't know, 9-10 years. And you will not see what you're worried about, which is flash the gingival margin. And actually, I wanted to show one quick thing because this will be a good wrap up, is what I didn't do is I didn't take out, I want to show you one quick thing before we wrap up because this will answer this question, is I want to take my screwdriver here, if my team gave me one. There we go. Thank you, team. And I want to take my tooth out, and I'm going to have you watch me the entire time so you don't think I had Hollywood magic here. But look at that. Oh, what a great, whoever asked that, thank you so much. That's what you get with injection molding. My material has migrated from the deepest portion of that preparation all the way around to the lingual, all the way around to the buccal. I am 1 to 2 millimeters sub G. There is no flash. I have an ovoid contact that's 2 by 4 millimeters. And you saw I worked pretty quickly tonight, but this is what you get every single time. I don't have a blowout here. I don't have a margin. I have a TRI, a tooth restorative interface. That's what I want with every single one of my restorations. That's what you'll get with preparing teeth with this Clark Class 2 preparation using heat injection molded composite, the 3M bulk fill Tech 1 that we used tonight, and a Bioclear matrix. That's a pretty good way to end things.
All right, I think one more.
All right, I told you I'll stay here all night if you want.
I know. Are the majority of composites, can they be heated, like omnichroma compules, re-enamel compules?
The answer is no. Not all composites can be heated. Solventum was the very first and one of the few manufacturers that spent, I don't even want to know how much, on all the testing to get FDA clearance to heat the composite. Some you can, some you cannot. There's some of the microfill composites you cannot. A lot of the major manufacturers, you can heat the composite, but just because you can and just versus having FDA clearance are two totally separate things. So you need to check with your manufacturer. But I can tell you, at least with the Solventum composites, their entire line of composites can be heated and have FDA clearance to do so.